Hello, everybody. I'm very happy to start this this webinar organized from WAC4U on thrombotic and thrombocytopenia events. We are very happy to be organizing this as an open webinar. We have different stakeholders all over the world here with us. We have more than 180 registered. At the moment, we are with 88 attendees. We can, all attendees are muted, but if you want to speak up, please raise your hand and we can unmute you also. We will have a discussion. And my name is Daniel Weibel. I'm the Secretary General of WAC4U. And we have several panelists. We will start with Miriam Stokenboom, who is the president of WAC4U and also a professor at the University Medical Center in Utrecht. And we have a second panelist, also Professor Steve Black, and he is from the Brighton collaboration and joining us from California today. Good. I think we can start then with Miriam, please. The floor is yours.
Well, thank you very much, Daniel, and welcome everybody for joining us. And I hope you can still see the presentation. I would also like to introduce Carlos Duran Salinas, who will also be joining us in this presentation on the more medical part. Some housekeeping rules. This meeting is being recorded, so if you do not want to be recorded or heard, please do not speak up. I think that's it. If you have a question or want to comment, you can raise your hand, or you can put a question in the question box. So that's an opportunity to start the interaction. So the goal for today is to align really to look at all the events that have been occurring around the AstraZeneca and also the Janssen vaccine, is that there are now a signal of thrombosis with and without thrombocytopenia, and clearly the field in the vaccine epidemiology or pharmacovigilance is that we need to act, and we see several people acting, and we felt that it was a good opportunity to actually see whether we can align across the world on how we will approach this more or less, so that we can actually compare data that will be generated. And according to our assessment of what is needed, it's based on how to estimate background rates of these events, where the regulators do observed expected analysis. So what events are we talking about? How to look at the combination of thrombotic events and thrombocytopenia. I think there is also a need for comparative studies, and then there are also clinical studies that will be needed. So today, we may have a large goal here, but we do want to start some interaction and opinions. So please feel free to share that if you want in any of the opportunities that you have in this facility. So to start off, a quick overview of reported cases that are in the literature or that have been reported in any of the regulatory meetings or the public health meetings. And Jim Buttery, I don't know whether he's here already from Australia. He may join us and may give some feedback on the Australian part. It started, I think, mid-March, when there were cases occurring in Austria and then later Germany, Norway, and there are several case series reported in the New England Journal. And what we see, this is just a screenshot of them, and we don't go through all of the details, but what is important is that there are several cases where there is a cerebral venous thrombosis or a splanchnic vein thrombosis, a pulmonary embolism, or other type of thrombosis in large vessels combined with a thrombocytopenia, so a low platelet count. Now, these are all occurring within 5 to 13 days, and in this series post-vaccination, so quite rapidly. And this is a quite rare combination of conditions. So that was actually signaling first in Austria, then in Germany and Norway. So this is the Greinacher case series. Then there is in the same issue of the New England, you can also find the case series from Norway by Schultz et al. A similar pattern. So what we are seeing is actually time from vaccination to admission, very short symptoms, and then the location of the thrombosis, cortical veins, sinus, portal veins, and then combined with a low platelet count. I'm going through this because I guess most of you may have heard about this, so it's just to set the stage and the basis for the discussion. So the overview of the thrombotic thrombocytopenia syndrome cases in the EU based on the AstraZeneca vaccine, based on the Prague meeting that happened on the 6th to 9th of April. This is the report. So the cerebral vein sinus thrombosis, 62 cases reported in the eurovigilance database. Medium time to onset is 9 days. With thrombocytopenia 53% and high fatality rate. Splanchnic thrombosis, sorry, 24 cases reported. Also here, time to onset quite short, although the range here is 0 to 32 days. This has resulted in an updated product information for the AZ vaccine, the Vaxzevria as it's called in Europe, which now states that severe cases presenting as venous thrombosis, including unusual sites such as CVST or splanchnic vein thrombosis, as well as arterial combined concomitant with thrombocytopenia. So this is the information on the AZ vaccine. There was also an analysis done by MHRA in the UK, and they were also reporting on a total of 79 reports, where there was a combination of blood clotting plus low platelets, and 44 were CVST, 35 in other major veins with thrombocytopenia. Last week, we heard from the US that the J&J vaccine, which is utilized in the US already, had some cases that seem very similar to the AZ syndrome, and there was a public ACIP meeting where all of the cases were discussed. And they were also mostly presenting with CVST actually, and then combined with low platelets or thrombotic thrombosis in other areas. So this investigation, of course, is ongoing, but in Europe, the start was halted. And I don't know whether we have Jim Buttery on the call or anybody knows from the updates in other parts of the world. Steve, do you know anything? I don't know whether we have Jim here. If not, then we will skip the update from Australia. But I think if we summarize that the cases that are reported around this signal is actually a combination of cerebral venous sinus thrombosis with or without thrombocytopenia, and other thrombosis with or without thrombocytopenia. And most of them seem to occur within 2 weeks after vaccination, and the fatality rate is high. It's very rare. But it's important that this gets investigated, and we hope that somehow we can agree on what best approaches would be. So that said, I would like to hand over to Professor Stephen Black, who will update us on the work from the Brighton collaboration on the development of a rapid case definition for this new syndrome. Steve, the floor is yours.
Okay, thank you very much, Miriam. Can you hear me okay?
Yeah.
Okay, whoops.
Yeah.
Okay, all right. So welcome everyone. I'm going to describe the work that's taken place largely over the last week and a half to develop a case definition for what we're calling TTS, or thrombotic thrombocytopenia syndrome. Next slide, please. So initially what we tried to do is do this more analogous to the way this was done with other Brighton case definitions. But all the hematologists were so engaged, especially in Europe, that we really couldn't put together a working group. So what we did do is take the British Society for Hematology case definition for a possible case of this syndrome that was developed to identify people for treatment largely, and merge that with the Brighton case definitions for thrombosis and thrombocytopenia. Unlike the British Society for Hematology case definition, we delinked this from exposure to vaccination, as is routinely done for Brighton case definitions, to minimize bias during case ascertainment and also to allow for broader epidemiologic studies. Next slide. So what we will do, what we propose to do then, is to use a case finding definition, which I'll describe in a minute, to identify a cohort of cases, and also to delineate a list of variables that we would want to collect on these cases, which so far is being done based on merging questionnaires from the EU and UK and Canada, and then develop a consensus document or final case definition to refine the existing one that I'll share with you in a minute. So the reason for going through all this is to make it very clear, this is a work in progress. This is not a final case definition. It's something that's being developed to collect more information. Next slide, please. So we're calling this a case finding definition, which is something new for Brighton. It's not final, as I said. The goal is this is a transition on the way to a final case definition. And the goal of this is to define the spectrum of disease of TTS and related syndromes, either in association with COVID vaccine or not. And the reason I said related syndromes is you've already seen this thrombosis thrombocytopenia syndrome includes thrombocytopenia in the definition, but some of the cases that Miriam presented do not have thrombocytopenia. So this is one piece of the puzzle. And the goal here would be to differentiate TTS from thrombosis alone or ITP alone in terms of case characteristics, biomarkers, or potentially mechanism of disease. Next slide, please. So this is available online. The link was in the first title slide, and thank you for putting that in. But basically, there are two components to this. There is a patient presenting with acute venous or arterial thrombosis and new onset thrombocytopenia, as confirmed by the two case definitions for each of those conditions, and no recent exposure to heparin, because heparin can also cause a similar HIT syndrome. So what we're proposing is the Brighton case definition for thrombocytopenia, being quite simple, as a platelet count of less than 150,000 per microliter, and a smear also being evaluated to rule out platelet clumping, which can lead to a falsely low platelet count. And the second piece is the Brighton collaboration case definition for thrombosis. It's still undergoing final review, but the current criteria are ones that we'll go through in a minute, and there are three levels of certainty, from a definite to a possible case, probable to a possible case. And we propose to classify cases based upon the level of certainty of the thrombosis definition, since we only have one level for thrombocytopenia. Next slide, please. So this is the level 1 criteria for thrombosis, and I'm not going to go through all of this in the interest of time, but except to say that this relies on imaging studies to define that thrombosis occurred primarily, or in some patients, a procedure that confirms the thrombosis, such as a surgical intervention, or a pathology in the case of death that is consistent with thrombosis. That's basically the level 1 criteria are that they are not they're not clinical, and this can be confirmed by elevated D dimers or other clotting studies. Next slide, please. We wanted to make cases, the ability to identify cases, more broadly available than just high-income countries that had access to these imaging studies. So we've included the level 2 and level 3 levels of certainty for thrombosis. And these specify clinical syndrome with either imaging study supporting that or elevated D dimers. So here you could just have a clinical syndrome and elevated D dimers for a probable case, or level 2. The next slide, level 3, is less certain, but it's a clinical presentation consistent with thrombosis or thromboembolic event, including those listed here, without any imaging or laboratory confirmation. Next slide. So if you go to the link, you'll see this, and this is basically just a graphic representation of how to classify these cases. And for some people, it's easier to follow this. It surely won't be easier on your computer screen now because it's too small. But I wanted to make you aware that we did do this. Next slide. So thank you. I'll turn it back to you, Mary.
Thank you, Steve. And just let's take questions at maybe we can have some clarification questions now on this before we move on. Are there any questions that people have? And otherwise, just put them in the chat. Daniel, can you see any questions?
No, I can. Yes, I can see, but there are no questions yet coming.
Okay, I think Catherine Smith is
here.
Yeah, Catherine Smith.
For platelet count, when does this need to occur? From Alexander Doroshenko.
Okay, so this is something, again, here, we're not identifying cases for clinical treatment here. We're trying to look at the landscape of cases and eventually define a time window prior to the diagnosis being made that the platelet count would be low. So the case finding definition is purposely vague and saying recent onset, but whether that turns out to be within 30 days or 60 days or 2 weeks, we have not defined that yet. But if there's a patient with new onset thrombocytopenia who has thrombosis, they would be considered a case for this cohort. And eventually, the goal would be, once the cohort is identified, to answer specifically what the risk window or time window might be.
And this is Alexander Doroshenko. I just posed that question. Maybe just another point of clarification. For sometimes the initial test can yield normal platelet count, and I guess the question is, would it be helpful? Like I guess in a clinical management depends on the severity of the clinical syndrome. If somebody's in the hospital, they will likely to have a series of a count, but I guess to rule this out, a thrombotic event with thrombocytopenia, what interval would be taken just to say that this is not this particular entity? And of course, we were talking about the thrombosis without thrombocytopenia, which would be a somewhat of a different.
Yeah, I mean, the goal of this case finding definition is specifically to look at the combined syndrome, so that if someone is, initially has a low platelet count and then has a normal platelet count and the next day has thrombocytopenia, I would think that would be included here. I would think it would be wise to, since we really don't understand the mechanism fully or what's happening here for all of these cases, The goal here is to have a case-finding definition for the combined syndrome of thrombosis and thrombocytopenia. But I'm presuming that we would also want to investigate cases with thrombosis alone and cases with thrombocytopenia alone as well, because usually things like this occur on a spectrum and not all the characteristics are present in each individual case. But since there was no definition for the combined syndrome, and that was what it was initially recognized within Austria and Norway for many of the cases, that's why we put this forth.
This is Dr. Catherine Smith. Can you comment on the thrombosis criteria, the phrase in the absence of an alternative diagnosis? I'm just wondering if, for example, when we're trying to establish whether a case meets the case definition, if we have a thrombotic event that occurs with many other risk factors for that thrombotic occurrence.
Yeah, I think the goal here is initially to be broad. However, if someone had a car accident and trauma and a thrombosis and thrombocytopenia with that, that might be a reasonable reason for exclusion. But at this stage, we're not proposing to exclude many people. So the idea would be to have a high bar for excluding cases until we can define the entity better.
Okay, thank you. And then just one more follow-up question for the case definition for the thrombocytopenia. Is there any thought about a repeat platelet count within a certain time frame that then is no longer meets the definition? For example, if you have a case where you have a platelet count that's slightly less than 150 and a repeat 24 hours later is normal, are we still meeting the case definition?
Sorry, at this point, yes, but I think that's a subset of cases that we would want to look at.
Thank you.
Because one of the things people have brought out is that either we don't know whether the thrombocytopenia is primary or secondary here, because thrombotic events can consume platelets in some cases, whereas if it's due to antiplatelet antibody that's causing the thrombosis with sticky platelets, then you would think the thrombocytopenia would be present early. So that you can see from the cases that Dr. Sturkenroom showed is that some of the cases don't have thrombocytopenia, and whether that is a different entity or not, we don't know. So we would want to collect all that information. It had been suggested that we would require 2 platelet counts to confirm that they really were thrombocytopenic, but that was left out because we thought we would just collect that information on these cases if they had one event of thrombocytopenia. Some might resolve spontaneously or have been false results, and others might not, and they may not be the same entity.
Thank you.
Thank you, Catherine. We have still a raised hand from James Kay.
Jim Kay at RTI Health Solutions. Just you're aware, because this is such a broad definition, that other rare diseases like thrombotic thrombocytopenic purpura, TTP, hemolytic uremic syndrome, disseminated intravascular coagulation, which can often be associated with thrombocytopenia secondarily, and even the thrombotic complications of COVID-19 infection, COVID-19, which can be associated with thrombocytopenia, would all fit under this definition.
Yeah, and we're aware of that, and I haven't gone through it because it's not finalized. There's a list of information that we would collect on each of these cases that would include COVID antibody as well as PCR status, whether there's sepsis or other conditions. We want to make this, at this point, and TTP is, may be a manifestation of the same. I mean, patients may manifest as thrombotic thrombocytopenia purpura as one manifestation of this entity, and we don't know that yet. So the reason it's case finding rather than a case definition is we want to find all these cases. I'm sorry if I'm saying this over and over, but it's different than we usually do, so that we can then stratify them or group them into different groups. And there may be other clinical entities that are identified within this umbrella, but we're erring on the side of trying not to miss any manifestations of the post-vaccine phenomenon that might occur by limiting the definition at this point.
And why is vaccine then not a criterion for identifying this?
Well, if you wanted to do a study, Brighton case definitions classically do not include vaccine status, because you want to identify the cases first in an unbiased manner without looking to see whether they're vaccine. And there's already, I'm aware, preferential testing for antiplatelet antibody in some countries depending on their vaccine status, and that's not a good way to do an epidemiologic study. So we're trying to ascertain the cases in a manner blinded to vaccination, and the same cohort could be used to compare clinical presentation if they're in vaccinated and unvaccinated individuals.
See, thanks.
Thank you very much. We have a question from Cindy Sue, who wants to know, what is the chronological order of thrombosis and thrombocytopenia? Does thrombocytopenia occur after thrombosis?
Okay, so that's a very good question, and one of the ones we hope to answer with a study that would be done on this cohort. This cohort will include individuals who had both phenomenon regardless of the order in which they were identified. Realizing in most of these cases, it's the clinical syndrome of the thrombosis that leads the patient to be evaluated. But we know with thrombocytopenia and association with other vaccines where thrombosis doesn't occur, is many of these can be asymptomatic. So, and we don't know really what the risk of thrombocytopenia alone is here, because they've not been reported in the cohorts that Miriam identified, even though there are cases with thrombosis alone without thrombocytopenia, but the focus so far has not been in the third group. The goal here is to identify cases for a descriptive study to answer these questions, basically.
Thank you very much. This is Cindy speaking. I guess in terms of operationalize the definitions, of what would you recommend? I know it's unclear currently, but what time window would you recommend? For example, if we anchor on the thrombosis event, to search for the event of thrombocytopenia.
I guess it depends on what the scope of the work is that you're planning on doing. If you're looking at thrombotic events alone, thrombocytopenia alone, as well as the conjoint syndrome of the two of them together, you would probably identify thrombocytopenia cases separately, thrombosis cases separately, and then look to see in the thrombosis cases how many had thrombocytopenia as well. If you're just looking at this entity alone, it makes probably most sense in terms of logistics and the amount of work required to require the thrombosis first, and then look to see whether thrombocytopenia was present. So you would identify two of the three potential check boxes, if you will, if you took that approach.
Yes, and I wanted to add, yes, so maybe we will discuss this further, because after this session, we have a section more on the operationalization in studies. So the timing and distance will be discussed further. Yeah.
Okay, thank you. Daniel Mines wants to know any guidance for assessing index date on the onset of the first symptoms or signs consistent with the diagnosis rather than the date of imaging confirmation, because the syndrome of strokes associated with cerebral venous thrombosis can begin with non-specific findings. What do you recommend on the dating of onset?
Yeah, I think I'll defer to the discussion Dr. Sturkenbaum just referred to in terms of how to operationalize this.
Okay. There are another 3 questions. Do we have time now? Or, I mean, we have all questions written down. We can easily come back also later. What do you recommend? Miriam,
It's up to you. You're
we have
there.
Then we continue. Yes, we have Anna Chioti, adenovirus-induced thrombocytopenia, the role of von Willebrand factor and P-selection in mediating accelerated platelet clearance.
Yeah, I mean, that is there. You know, there have been a lot of mechanisms proposed for what might be causing this entity in terms of interactions with adenoviruses. For example, is one of them, and there's some information on thrombocytopenia, for example, when adenovirus vectors are used in genetic studies. This is something that needs further study. I really can't conjecture on what the mechanism is here.
Okay.
Thank you, Daniel.
Okay.
Does that mean we can continue? Are there any other
We
questions?
have another 2 questions from Yu Li Wong. Does Brighton collaboration plan to develop a case definition after this case finding, according to this case finding algorithm?
I'm sorry, I was on mute. Yes, that is the intent. This is an intermediate step to facilitate studies that will generate information that ultimately will develop a classical Brighton case definition.
Okay. And we have one from Sudat Samaravira. Could there be transient mild forms of cases that may undergo unnoticed?
Yeah, I don't think we know that, but my guess would be yes, because that's sort of the way most diseases work. This could be a transient phenomenon in some people. So we saw that with intussusception following rotavirus vaccines, where initially intussusception was the only entity that was looked at, but afterwards, when people became sensitized, they became aware that mild bleeding or transient abdominal pain or colic was more common in those infants. But this is something we'll have to wait and see how big an iceberg, if you will, there is with cases under the water that we're not identifying yet.
Okay, we are through with all the questions. Thank you.
Well, thank you very much, then. So in this part, in the next part of this webinar, we would like to discuss like how we can actually operationalize this, like what approaches should be taken in epidemiological studies that are investigating this, either for purposes of background rates or for more risk evaluation studies or safety studies. I would like to introduce Dr. Carlos Duran Salinas, who is working with us and has been looking into codes and the definitions and the proposal to do this. So I would maybe, Carlos, please, the floor is yours.
Well, thank you, Miriam, and hi to everyone. Well, based on what has been said till now, we would like to present to propose all of you the following classification for EPI studies. The first, what we propose is to go an approach where events can be classified alone, of course, as thrombocytopenia and cerebral venous sinus thrombosis, and VTE, meaning venous thromboembolic events, and then arterial events. So within the VTE, we are proposing to split this analysis within an anatomical way of thinking. I mean, taking the main central veins, meaning central, basically the abdominal veins, this splenic, portal, abdominal, the main cava and aortic veins, and then all the pulmonary vessels and DTV, meaning limbs. And then the arterial overall events, stroke and myocardial infarction. So, and then a combined approach where we can go up to thrombotic events classified by thrombocytopenia, yes or no. So this is basically the main proposal right now. And then, of course, we have a point to discuss about that, if it should be included or not. This is an open discussion to all of you. Yeah, next one, please. Well, this is more or less what I've said right now, is to go on thrombotic events and then to looking for if there is presence or not of thrombocytopenia. And this is exactly the question about the risk windows that was raised just a few minutes ago. The proposal is to go and search for events on weekly basis, and then on monthly after 4 weeks of the second dose. And then I'm not sorry, I have something here that's I cannot see very well. Well, this how to measure the distance between the thrombotic events and thrombocytopenia. That is basically what the proposal is, to go basically on the same hospitalization plus 10 days. I mean, or 10 days. So with exception of the limbs, which of course we know that not always we will have hospitalization cases, hospitalized cases. No? And then we have some discussion points about if the day 0 must be included or not in the risk window. And the distance between the thrombotic event and the thrombocytopenia for the identification of cases. Yeah, I think that's all, Miriam. Well, these are the more or less the codes and concepts. Here the main doubt was if we should include or not things are idiopathic purpura thrombocytopenia. Yeah. These are the concepts of codes. I think I don't have to go that much here. Yeah, and then we have this the arterial thrombotic events, and then where cerebral infarction, stroke, and myocardial infarction are included. Probably the main I mean, question mark here is we should include or not angina in the algorithm. And coming back a little bit to the proposal about the VTE codes and concepts, well, there's this major concept of splenic events where it takes the portal cava, abdominal, intestinal, splenic, and we doubted a little bit about if it should be included or not, the renal events or not, the renal thrombosis. And yeah, also if should be included or not obstetric cases, I mean in pregnancy and postpartum of cases. And I think is the last slide.
Yes, so
Yeah,
I think this is, thank you very much, Carlos. And I think this opens the door for discussion. We do have Jim Buttery now also with us in the panel. Hi, Jim. Welcome.
Thanks very much, Miriam.
Yes. So, Jim, I was wondering, we went through the presentation and we presented some of the cases, but if you have some experience you want to share from Australia and what you're seeing, and that would also be good. But at this point in time, maybe first open the floor for discussion about the operationalization of these type events and the proposal that was actually made. And I think it's best then to go to this slide, where there is a proposal on how to handle the analysis in terms of, like, let's look both at the events separately as well as with thrombocytopenia. So it's a stratified approach. And then to split the thrombotic events in these main categories, so cerebral and then VTE, which you may then subcategorize, and arterial. So maybe that's a first point that we should discuss, and then whomever can analyze this, it would be good to, since the risk window is not known yet, I mean, it seems to appear within 2 weeks, but probably there may be late and we just haven't observed. I mean, it's unclear at this moment, I think, although the majority of the cases are there. So what approach could be taken in epi studies that we capture this hazard function without, taking predefined decisions? So whether we can have some recommendations on how to approach this across the world. And then I think the next discussion is also about this distance. So why 10 days? It's arbitrary. I think at this point in time, it's not fully arbitrary, but it's a suggestion, as we do need some distance, I think, to take it here. If you take it longer, you include like a lot of waiting time somehow, and it limits you in the speed by which you can analyze this phenomenon. And at the same time, most of the cases we are currently seeing seem to co-appear and within 14 days. So that's a bit of the between 3 and 14 days. So that's where the 10 days came from. But it would be very good to get some opinions from the audience on this operationalization of how we are studying the co-occurrence of both the thrombotic and the thrombocytopenic events. So I don't know, Daniel, whether there are questions already. The floor is open, and maybe Jim, if you want, maybe you can kick off, Jim, if that's okay for you. Knowing that I put you on the spot.
Thanks very much, Miriam. I feel a bit of a fraud, as to date Australia's only had 3 cases proven for this condition. I think the 10 days seems a reasonable proposal. I think in Australia it's going to be a little complicated in that while it's likely that all of the thrombotic, thromboembolic episodes are likely to be captured in hospital data sets, it's unclear for us whether thrombocytopenia will be all captured within the same data sets, or whether we need to broaden that to include other external laboratory and primary care data sets. But other than that, I think the time courses proposed seem consistent with what's been described so far for both AZ and the J&J cases. Over.
Thank you, Jim. Yes, I mean, this is more like a hospitalized condition. So maybe if there are people that have questions, Daniel, can you indicate
Yes,
this.
there are questions here. Yes, we have again from Cindy, we have a question for the distance between thrombotic event and TP. Would you recommend anchoring on the diagnosis of thrombotic event or the admission of hospitalization to search for TP?
So this comes back to the discussion, I think, as an index date. So please, panelists, chime in here. I think what we have learned so far from whenever these cases were presented, that mostly the first presenting condition was the thrombosis, and then there was thrombocytopenia was found, as Steve was just indicating. And so it would be a good anchoring point, I think, the thrombosis, but we should not exclude if the thrombocytopenia was before. I think we should not exclude it and take the earliest day for any of these onsets as the index date. So that's also why the proposal is to have 10 days plus or minus. So so there is like a caliper approach around them, but quite close together to allow also that we don't introduce potential biases there.
Miriam, this is Steve. Can I interject and ask you a question? The thrombocytopenia part of this was focused on codes, ICD 10 or 9 codes. But what about if you identify thrombotic cases and then looked at laboratory confirmation instead? Would that be more difficult, do you think, or inappropriate?
So that would require that you actually can go back to the cases and review them either by chart or do additional analysis. And I think currently, I mean, that would be ideal, of course, but at the same time, I think we are in a reality where sometimes now we need to give responses quickly about background rates that exist and how often does this co-occur. So I think for different use cases or study types, that may or may not be possible. So I think an operationalization that would just rely on the existence of the or on the co-occurrence with some distance would be good. I guess. I don't know what other people think. So please, people, feel free to provide your opinion in the chat or.
Yes, I would like also to ask Daniel Mainz if his question is answered with this on the onset date, the index date.
Not completely. Are you able to hear me?
Yes.
Okay, thanks. The concern, my concern is that the event has been going on for some time before you actually see the diagnosis recorded in a health record. And I've not reviewed the case series published so well to know, or to know if the information is even there. So let's say I have a cerebral vein thrombosis. I may present with a headache that until something more severe happens, I may not seek medical attention. So it could be that we are, if we're anchoring to the diagnosis date, we may actually, that may not be the proper index date. It's the same issue I'm talking about that occurs in epidemiologic studies of multiple sclerosis, where the index date is usually reset to the first set of symptoms consistent with the diagnosis. One way to deal with this is that if we think is just maybe to make the window a little bit longer, allowing people to get diagnosed if there is going to be some delay between the onset of the process and the symptoms and then the clinical confirmation.
Okay, Daniel, can I try to, I thank you for that contribution. And I think, so one thing is like where to set the index date. So what is the start? And what is astonishing to me after having lived through the narcolepsy occurrence or signals is that this is actually happening quite rapid after vaccination as we see it now. So it's quite an acute onset type. So I agree with you that ideal is to use the date of symptom onset if you can find that. But I also would like to argue somehow is that probably the error we are making there is not so long. So it's quite a it's probably there's probably it's easier to define the index date on the date of hospitalization in the absence of symptoms. But if you have symptoms, I mean, that is probably the preferred date. I agree.
Okay, thanks very much.
And this is, so there are other questions, I think, in the chat.
Yes, I have a comment from I need to, I will take the one first. There are some, there's a question about the incident event. Is the recommendation that the thrombocytopenia is defined as incident and therefore we impose a time period prior to the event without the code for thrombocytopenia? For example, 365 days of clean window or something like this, from Huili Wong.
Yeah, I think that is typically what is being done unless people see what is the setback. So we do want a new onset, as Professor Black also stated, like we do want new onset thrombocytopenia. So we do need in the operationalization some naive period or wash, or so. Does anybody object to this? I mean, you can write that in the, so we could say like, 301 year of. I think nobody would be objecting to that.
Yeah.
Hi, this is Willie. I just wanted to suggest this for consideration for others, because as we're going through this, defining the incident thrombocytopenia also then decides, it goes by the index date. Do you want that to the clot event also, or do you just want this prior to thrombocytopenia, or do you want it to both? And we don't necessarily discuss this now, but just wanted to let you know that this is the internal discussions we've been having. Thank you.
Thank you very much.
Yeah, so I would like to ask Stephen and Jim here as well, because I would say that, in the combination of thrombocytopenia and thrombosis, you would always choose the first occurring as the index date. Would you agree? So we don't anchor just on thrombosis. It's just that most of them will be presenting as thrombosis and then the thrombocytopenia is noted. But if they would be diagnosed first with thrombocytopenia and then have a thrombosis, we would take the index date as the thrombocytopenia. Would anybody object to that? Steve, what do you think?
I think that's reasonable. For most of the cases, I think, as you said, the thrombosis will be the defining event. But if for some reason someone has thrombocytopenia first that's identified, that would make most sense.
Yeah, I agree. The clinical workflow is such that you may get information about thrombocytopenia before you get clinical information about thrombosis, although I think, as Steve said, it's likely to be the other way around.
Does that help, Yuli? Then there is, I think, a question from Hanna Mullerova. Hi, Hanna.
Yes.
What is your view on the I63.6 cerebral infarction due to CVT? That's a very good question. I mean, there was a recent paper by Taquet this weekend, I think, that did a sensitivity analysis that included this code in the in a sensitivity analysis. It is a code that is part of the stroke list. So stroke, it would be captured as stroke. So the question is, do we want to use this as a CVT? And I would like to ask again, Steve and Jim here, what is your thought? Would you want to classify this as a stroke, or go ahead, Hannah.
I would just add to it that this code has been used in validation studies of US claims data, about 2 studies published in the last 5 years. So it's been used in other studies as an integral part of the definition.
Okay, so I would like to, Steve, what do you or Jim, would you want to classify this as a CVT or as a ischemic stroke? So
I would ask a neurologist, actually. I wouldn't want to answer that question.
okay.
Yeah, I think similarly, when we've discussed with our central coders behaviourally in our health system, it's not used for CVT, but it is included as one of the non-specific codes for infarction.
Okay, so important is that, you know, whether it's actually CVT or classified as ischemic, that is actually being picked up. And it, yeah, at some point it's included in the event definition, but of course it can be a major part then of the CVT because it's very rare. So it may have an impact in the number of cases and the misclassification. So I think the comment here and the recommendation would be to talk to a neurologist and then to take a decision on that, Hannah. Then you have another code, which is the G08, which is of pyogenic origin. Does it align with the notion that these events are non-infectious? So the question, I think, I don't know, Steve, whether you want to comment on this, whether you would want to include this, and I think this then would relate to the code. Let me see where I can find that. Yeah, so it would be for the CVST.
I'm sorry, for which code?
ICD-10.
Right.
GOA
Correct,
code.
Anna? Yeah.
Yes, it's the GOA code in ICD-10 group. Just that description, there is a very broad description of this code. It's been also validated, but I've been just wondering really about the origin of that code and what type of CVST it is related to. The description even here on the screen implies phlebitis, thrombophlebitis, intracranial sort of origins. It's not clear from the description whether it would be coded for in sort of the diseases of infectious origin rather than non-infectious.
Yeah, I'm not clear. I think one thing you're going to run into is that different localities will use these codes differently. But you know, as the description is written, there's no thrombosis in the term there. It's inflammation of the vein, and that could occur without thrombosis or could lead to thrombosis. So I don't know how the coders would use this. If it were me, I would not use it for a thrombotic event. I would use it for an inflammatory venous event, which could be infectious, as was just said.
Okay, thank you, Steve. I would like to ask Eric Weintraub. He is responding actually to the prior question that we had on the I63.6, stating that the VSD asked a neurologist and the suggestion was to use it for CVST and keep it, I think, also in ischemic stroke. Eric, do you want to comment on that? And maybe did you also check in for the GOA code and have an opinion about that? So Daniel, can you unmute Eric?
Yes, he is unmuted, Eric, please.
Yeah, hi, this is Eric Weintraub. Can you guys hear me? Yeah, so we spoke with neurologists for VSD, and per the recommendation was to include the I63.6 and keep it in both categories, the CVST, then also in ischemic stroke. And we also right now have GO8 in our definition for CVST. And ironically, we've identified 10 automated cases so far of CVST, and 8 of the 10 had that GO8 code. And we've confirmed of those 10, we've only reviewed 9 so far quickly. 4 do seem to be probable, potentially CVST cases, but they all are without thrombocytopenia. But it does appear that the GO8 code was useful in identifying Now, they could have had the other codes as well. What I'm looking at right now doesn't have all of the codes they were given, but the G08 was the primary code that did help us identify CVST. But then we go into the record and actually confirm whether or not they had thrombocytopenia or not.
Okay, yeah, so this is then the case finding for the CVST, and then of course there should be the combination with the occurrence or the co-occurrence of thrombocytopenia or within distance. Maybe Eric, now that we have you unmuted, I mean, did you talk about distances already within the VSD, like between the occurrence of CVST and or thrombocytopenia?
We haven't gotten that far yet. We'll probably have that conversation tomorrow, actually. It was one of the things that we discussed would be our next steps in doing exactly what's outlined here, is look for some of these key conditions, the VTEs, the pulmonary embolisms, the CVST, and then combine them with, some sort of thrombocytopenia definition, which for us, probably would be platelet files and looking at lab files and requiring platelet tests, but we haven't completed that in terms of that conversation about what would be our the time to look for plus or minus days to look for the thrombocytopenia.
Okay, thank you, Eric. I know we are at 5 o'clock and we are over time. We have, Daniel, do we have other questions?
Yes, we have a few questions and a few comments also. We can, yeah, if you would like to take some more, we can do that. If not, we can discuss them online. We can make an email conversation or on LinkedIn, or we will find out a form to go on with the discussion.
Yes, I think there are two comments. I looked at it quickly that oh, there are much more now coming in. So so let's do the following. So I think I would like to respect people's time, and we close this webinar now. The questions are recorded, so we can actually come back to that. There is discussion, I think, on the G08 code. I see also Dani Prieto who's commenting on that. I think the question is about, one is case finding, and then what we just learned from Eric Weintraub, I think, is that there are ones that you capture and probably they need validation because there may be a lot of false positives potentially in there. So I think it's important that we realize that. We will come back with the answers to the questions that people have, and I think for now it would be really good or to thank you for your your presence and the communication and the contributions to the discussion. We do want to say, like, if there's any questions, please write to this secretariat address, and we can have maybe a follow-up conversation or develop some type of approach or an operationalization approach to studying this condition. So Daniel, thank you very much. Do you want to close out?
Yes, I also would like to thank you very much. We were reaching by times during the webinar the maximum of 151 participants. I think this is showing that this was a huge success, and thank you very much for your active participation, and also thank you very much to our panelists, to Carlos, Jim, Miriam, and Steve. And if you have any questions, please drop an email, and also we will make a recording of this available and follow up in one way or the other on the outstanding questions and discussions. Thank you very much. Have a nice evening. Bye-bye. Hi, Miriam. Very nice. Good.
Miriam, more Miriam, start with you.